Hello students, today we'll talk about of a systematic approach how to read a chest x-ray. ठीक है, I'll give you a checklist uh, utilizing which anyone can interpret a chest x-ray. Basically, how to systematically approach a chest x-ray in general. So first of all, we'll see that how does a chest x-ray appear and why does it appear that way. Some areas we see on a x-ray film, some areas appear as what we say trans radiant. What does it mean? It means hyperlucent or darker, like this. ठीक है, rest of the areas they appear what? They appear opaque. ठीक है, like the soft tissues. Now why so we'll utilize this x-ray principle here, attenuation of the x-ray beam. ठीक है, कोई एक्सरे किस तरीके से दिखता है, दैट डिपेंड्स अपॉन द attenuation of the x-ray beam. Attenuation of x-ray beam will depend on what? Attenuation of x-ray beam depends upon density of the tissue through which the beam is passing. Like, to attenuate the x-ray beam, to reduce its quality of penetration. ठीक है, so utilizing this principle, what we can interpret is soft tissue, bone, air, which of the following now it is having maximum density? Bone is the densest here and air is least dense here, or we can say gas. ठीक है, so bone will attenuate maximum, hence will appear opaque. Utilizing the same point, air or gas is least dense and hence will attenuate least and therefore appear as radiolucent or transradiant or hyperlucent. Now, as we all know, soft tissue has intermediate density तो इंटरमीडिएट अटेन्यूएट करेगा and will appear gray. ठीक है. Hence this air is appearing hyperlucent. These bones, they are appearing opaque, and all of this soft tissue is appearing gray. Now we'll come to how to interpret a chest x-ray using a checklist. First of all, we'll see whether a chest x-ray is PA or AP. Why so? What is the importance? We'll see. As we know that AP technique gives inferior quality radiographs. Hence, we cannot compare them over a period of time. Why PA? PA is a standard technique. We can compare subsequent X-rays. Now, what will happen if we are provided with a AP radiograph? So, as we all know, AP will produce magnification. We cannot comment upon heart and mediastinum. We can not compare subsequent radiographs. Next, we'll come to inspiration. For inspiration, we'll see how many ribs we can see through this X-ray. ठीक है, we'll count the ribs. Usually we should see 6 or more than 6 anterior ends of ribs above left hemidiaphragm. Now we'll count the ribs. This is first, this is second, this is third, this is fourth, fifth, sixth, seventh, and eighth. So this X-ray is having adequate inspiration. Now we'll see how inspiration will affect an X-ray. Inspiration, if adequate, will expand the lungs fully. But if not adequate, then will lung vessels will appear crowded and hence will mimic basal infection. Now we'll come to rotation. For rotation, what will we do is we'll draw a line through the spinous processes of upper thoracic vertebral bodies, preferably T1 to T5, and then we will compare the distance between this line and medial ends of bilateral clavicle. The distance of both the medial ends of the clavicles should be equidistant from this line to say that the X-ray is known rotated. How will rotation affect an X-ray? We'll come to the point now. Rotated X-ray will lead to altered prominences of hilar as well as mediastinal structures, as well as will make ipsilateral side appear darker on chest X-ray. Then we'll come to the point trachea. Why we should see the trachea? We should see and compare the trachea. It should lie in midline or slight towards right because of arch of aorta on left side. If not, then it will suggest shift and will lead to the diagnosis of either collapse or effusion. Basically, it will suggest mass effect or ipsilateral pull on trachea. Next, we'll come to heart. By heart, I want to say that we will see the CTR. CTR stands for cardiothoracic ratio. What do I mean by saying this? The ratio of cardiac sellout versus thoracic cage. Cardiothoracic ratio. Now we'll see how to calculate cardiac ratio. Cardiothoracic ratio. How will calculate CTR? What we'll do is draw a line through spinous processes of vertebral bodies. Then maximum cardiac diameter on each side. As we all can see, this is the farthest point here. We'll draw a line. This is the farthest point here. We'll draw a line. I'll mark this A and this B. And what will I do? I'll take maximum transverse thoracic cage diameter and I will mark it as C. For CTR, cardiothoracic ratio, it would be A plus B upon C. And it should usually be up to less than or equal to 50% on PA radiograph. Now we'll come to next point, that is diaphragm. As you can see, both the domes of diaphragm should be clearly visible from one, this costophrenic angle, left costophrenic angle, this is the right costophrenic angle, this is the left costophrenic angle, this is the left cardiophrenic angle, this is the right cardiophrenic angle. Both the domes of diaphragm should appear well defined and throughout. If not, what will it suggest? If obliterated, we should look for any pathology involving the adjacent lung fields. Next, we should see the cardiac borders. All of the cardiac borders should be well defined and should be clearly visible. All of the cardiac borders should be clearly visible. We'll see what are the cardiac borders. Right cardiac border. This is the right cardiac border. This is the left cardiac border. Now we'll see what are the different components making them. Superiorly, right cardiac border is formed by superior vena cava, then right atrium, then IVC. On the left, aortic knuckle formed by arch of aorta, pulmonary artery. So this would be aortopulmonary window. Moving downwards, this is the left atrial appendage and inferior most left cardiac border is formed by left ventricle. Inferior cardiac border is formed by diaphragm. Here, right medial most aspect of right diaphragm. Here, medial most aspect of left diaphragm. This is the heart. All of these cardiac borders should be well defined and should not be obliterated. If obliterated, what does it imply? That there is some pathology in the adjacent lung fields. We should look for any pathology. Next, we'll come to the hilum. First of all, what is the hilum? I'll highlight. These are the hilum. This is the right hilum. This is the left hilum. We'll see what are the structures forming hilum. Hilum is usually formed by, mostly it is formed by vessels and most commonly by pulmonary arteries. Almost 95% of hilar shadow is formed by the pulmonary arteries. Then how we should assess the hilum. We'll see this is the right lower lobe pulmonary artery, this is the left lower lobe pulmonary artery, this is the upper lobe vessel, and this is the upper lobe vessel here. So we'll make the hilar V points here. This is the V point of right side, this is the V point of left side. Hilar V point. Now we'll assess the hilar V point. We'll compare the hilar V points of both the sides. As you can see here, left hilar V point is located superiorly as compared to the right one. And what is the reason for that? Left hilar should be always superior, or in some cases at same level. And what is the reason for that? That the left main pulmonary artery usually rides over the left main bronchus, and the right pulmonary artery travels anteriorly. We should compare a hilum by seeing its we should compare hilum by 3 points. What are these? These are position, that we have seen that superior hilum should always be left one. Size and density. Size, if enlarged or not, then density. Density of both hila should be similar. If one more than other, if not similar, then it will suggest either a mass or a lesion or a nodule. Next, we'll see the bones. We will look for any fracture, any rib lesion. In some other video, we'll talk about how to differentiate between whether a lesion that is appearing on a chest x-ray is a rib lesion or it is located inside the lung fields. Basically, whether it is rib lesion or parenchymal lesion. At last, we should see this hidden areas of chest x-ray. What are those? These are apex, then around the hila, then below the origin of diaphragm, below the horizon of diaphragm, and what? Retrocardiac area. These are the hidden areas of X-ray and we should clearly see them. These are the hidden areas. This is the apex, around the hilum, retrocardiac, and below the horizons of diaphragm. These, why these are called hidden areas of frontal chest X-ray? Because they are usually not seen very carefully, not assessed very carefully on the frontal projection. And what we'll do for these areas, we will request for a lateral chest X-ray whenever in doubt, after seeing on frontal chest X-ray. This was all about the checklist and how we should see the X-ray. Using these points, we all can assess X-ray in a systematic approach. Okay? We'll revise whatever we have studied. Whether a X-ray is PA or AP, what impact does it have? One more point that should be added here is seeing and comparing the previous X-ray. That should be added. Thanks for watching.